everybody will leave the hall, So I think this is important concept you need to remember is that, cancer is very heterotypic in nature. There are a lot of many different cell types which participate in this business at this play. Again, those cells could be a very important target, and the cell type which is a topic for us, in this is these immune inflammatory cells and immune cells which infiltrate the tumors. And as we were talking about those immunoediting, at the first step when we are talking about the elimination process, you can see the population of cells which enter into the tumor. Those are all the cells which they need, but as the tumor progresses, those cells, you don't see them. As I said, if you look at the tumors, you hardly see any T cells, which is the major cell component, if you see within the tumor, will be your tumor-associated macrophages or neutrophils, and those are the two immune cell types which are, Another important thing you have to understand is that when you look at the metastatic environment, probably you will have a very different profile. The cell types in the metastatic site will be different compared to the primary tumor. And most often, the metastatic sites are more inflammatory in nature, but the cellular population which gets recruited that site, most often they favor and support the metastasis. And that's very interesting because these are isolates. These will be not, like a 2 kg tumor or huge tumor. These will be very less than 50 cells, at the time when they were getting treatment. And these tumors basically will be left out because the therapy, never targets. It's very difficult to deliver drug to bone. Okay, it's very difficult to deliver drug to liver. Okay, very difficult to deliver drug. And these are normal bone, normal, although they have metastatic cells, but for most purpose they are normal. So it's very difficult to target this metastatic site. But one cell which goes everywhere, one cell type, not cell, one cell like immune cells basically travel everywhere. They are basically going through circulation and they are traveling everywhere. If they can be armed effectively and if they can be, trained right, probably they have the potential or capacity to go and chase and go and find these micro, metastases or fewer, they call it minimal residual disease, MRD. They can go and find this minimal residual disease and can easily clear them. What the environment does to tumor, it provides them shelter, it gives them survival benefit, and it gives them security. This is what that homelessness I was talking about. That they have to find the right home where they can survive and they feel secure, and the host basically provides that. And in most cases, if the host is not supportive, these tumors, although they will reach there, but they will never form tumor or they will never form metastasis. So this is a very simplified version of roll-up microenvironment. If it is favorable, it can support the malignant phenotype. There are both positive and negative regulators of those processes, and you can find them. There are more positive regulators to enhance malignant phenotype in favorable site compared to unfavorable site. And one of the best example when we look at, I told you that if you put colon cancer in skin versus colon cancer in colon, you will find these expression of different factors will be very different. Most often, the tumors which are growing in unfavorable site, they are avascular. They don't have, neovascularization or angiogenesis, and that's one key event, which happens and which are essential for metastasis. And there are many other, processes which you can identify depending on the tumor type. So there is a delicate balance which exists between tumor inhibiting and tumor promoting function in the microenvironment. Current approaches which we have for cancer treatment, you all are familiar. Surgery, of course, surgeons love to do surgery, and if you go to surgeon, they will never say no, so, and I can tell you that God and after God, there are surgeons, okay? How many of Really, they think that they can cure everything, okay? And they do, they do a good job. But they are so confident, okay? They have to be confident. They are playing with life, okay? Somebody is sitting on the table open, and they have to take care of that. So they have to have that mentality. And oncology management, surgery is a major component. If it is surgically resected, okay, if it is possible to do surgery, I can tell you it's a good news. It's good news because the tumor is either localized or the surgeons have, they can take it out. Even in pancreatic cancer, which we are looking into, 7-8% survival rate, if it is resectable, you are looking into survival rate of 60%. Think about it. If brain cancer, brain tumor, if it is resectable, you are looking into survival of 5 years to 7 years. If it is non-resectable, you are looking into 5 to 7 months. So I think surgery plays a major role in disease management. Of course, you have chemotherapy and radiation therapy, which is another major, regimen. Targeted therapy has already come into picture. Many of them have been approved by FDA, and immunotherapy is also another important regimen in controlling this. But I can tell you, malignant disease always fatal. Okay, we are looking into once the tumor is metastasized, that's dead sentence. Here is a nice diagram looking into different therapies which were developed at different time point. Every time when you think about any process or phenomenon, history makes a huge impact. If how it all came to the picture. Cancer has been in existence, and at least people have tried to treat them 1600 BC. Before 1600 before Christ. First written description of cancer in ancient Egypt. Okay, so it is not a new field, and actually, even if you look at the immunology, tumor immunology, somewhere in 1863, they did describe the immune infiltrates within the tumor and roll up those immune infiltrates, very early on in the tumor. X-ray was discovered sometimes in 1890, and coleotoxin is an interesting thing. It was the first immunotherapy, which was developed. The coleotoxin is a bacterial cocktail. It induces production of tumor necrosis factor, which was the first, and it was a big hype, that when they discovered TNF, tumor necrosis factor, they thought they can cure cancer because it was able to kill cancer cells. Okay, and coleotoxin was the first, immunotherapy in real life which was used to treat cancer. So this is the first immunotherapeutic, it is coleotoxin. Nitrogen mustard and most of the chemotherapy actually were developed during Second World War. Do you understand why? And do you know why? Even the use of X-ray as a oncotherapy, as a treatment for cancer, they were all developed during Second World War. So during Second World War, they were not able to keep up with sterilizing, these wounds. There were a lot of soldiers which were coming up with a deep wound, and cancer basically is wound that never heals. So they were not able to keep up. So they basically put these patients, with the wound which never heals under these X-rays, okay, and they saw that they can cure. The first chemotherapy drug which was discovered was 8-azaguanine, okay, and this drug was developed in 1948-49 and by Bristol Myers Squibb. And actually that was again not done as a chemotherapy drug for cancer. That was they were trying to make an agent which can try to prevent the wound process. They can prevent the wound formation, especially those long-term wounds which they were seeing. And again, these research were all done by female, by the way, because all men were all fighting war. Okay, so all the labs were basically were run by women usually. So they have played a major role in developing X-ray as a treatment for cancer, or developing these different class of chemotherapy. So that at that time they were developing these nitrogen mustard, which came out as again an agent to prevent wound. 8-azaguanine is a derivative of this. And then in 1970s they discovered these oncogenes, tumor suppressor genes, brought different treatment protocols. IL-2 came in 1992 again. And then in 2000, there was a big explosion of a lot of different things and targeted therapies, which are listed here. In 2001, actually, the first, this targeted therapy came as a kinase inhibitor for this ABL in CML. This is called Glivec, which is a compound which is commonly used to control this CML patient who have these mutation, ABL mutation. And Glivec is one drug which is like a wonder drug for these patients. These patients, all they have to take this drug forever, and they will never get recurrence of the disease. Okay, but only thing they have to take it for life, which is okay, but they don't have to worry about cancer. Angiogenesis inhibitor came into picture at this stage. First cancer vaccine which was approved in 2010, this was against prostate cancer, Spirocell T. And this cancer vaccine was taking the cells from the patient, ex vivo expanding them and reinfusing them back into the patient. The company went bankrupt, now it doesn't exist anymore, so because it was so expensive and there were insurance companies were not paying, for that. Now have a lot of excitement against these CAR T cells, which we talk about it. These CTLA4 inhibitors are PDL1 and PD1 inhibitors, in immunotherapy. So actually, immunotherapy has taken a big role in late 2015-16 picture, and the new cancer therapeutics are basically involved into this area. Even these oncolytic viruses which have been developed, this also functions in enhancing the immune response. Of course, they kill the tumor cells directly, but it creates a massive immune response, which is good and bad news because these inflammations which is created by these oncolytic viruses are mostly often fatal in nature. But those patients who survive those side effects, they have cure, and they have tried it in brain cancer, and they are trying in other cancers too. And now they have also done this combination of these CTLA4 and PD1 antibody together. And I will show you the data, and you will be surprised. It was published last month, okay? And you will be really surprised to see how much synergism these two antibodies together have. So I think there are a lot of hope. I hope they all end up, in doing well. But the future, of course, all these treatments are very generalized. These are not patient-oriented. These are all targeted to a population of patients. They are hoping that they can, make it more individualized because now they have a potential to do mutanome. All the mutational analysis of profiling. They can do all the immune profiling. Now, based on the next-gen sequencing, they don't even have to go the flow sorting to find out which cell types are infiltrating the tumor. They can do something called, what they call it, I will come up with it. It's a cytostressor. Basically, they can, based on the profile, expression profile, they can create the infiltrates, what kind of cellular infiltrates these tumors have. And it's all done in real time just based on the mRNA expression, not looking into what cellular markers these have. But what we have currently, this slide I show right at the end, that we have treated mice many times, okay? I have treated mice, okay? I have published, many studies where we have cured cancer, but everything fails, and actually in this the models which we use is model, right? Models are models, okay? Your model is never a perfect, but your model depends on the type of question you ask, okay? So never get discouraged if somebody says, oh, what you are doing is not right, okay? All you have to understand that what question you are asking, this is the right model to do it. If you can suggest something else, I will be happy to consider. But don't, get discouraged by saying, oh, this is not the right model, okay? But model is artificial, where you can ask a question, develop a model, do the experiment, and then you will have the results to move on. So mouse is a good model. We do a lot of preclinical studies, which you can do, very easily and reproducibly. But patient is very different, okay? So we cannot make mouse as a man, or man as a mouse. But one thing is very provocative, okay, which is this one, a small tumor volume before metastasis, initiation therapy, and after metastasis, after metastasis have established legal. So when you compare the size of the mice and human and size of the tumor which we have in mice versus human, it's a phenomenal, huge difference, okay? If the human tumors are just like the tumors we treat in mice, I will have cure, I think I can cure cancer even in my human. Size matters. I think the size is very important, and that is very critical. So, and in mice, no matter how big the tumor gets, still we can cure it. But in human, if you compare that size to human size, basically the tumor has to, basically is very tiny, and that maybe we will not be able to detect it. The treatment which we do, most often when we are doing preclinical treatment, we know when to start the treatment, okay? Because based on the biology, we can say that, we will establish the tumor, 1 week or 2 weeks later, we will start the treatment. In patient, we don't have that luxury, okay? You don't know when the tumor was started or initiated. Treatment will start when the patient show up in the clinic, okay? So you don't know from which stage, you are starting to treat these patients. So I think there are a lot of variability. So I say therapy fails, patient don't, and that's why we have this mortality. So at the end, all I can say is that, I hope you understand that these malignant cells, basically, they exploit the host homeostatic process for their growth. They are very smart. So, they can bypass or they can survive any insult you can give them. And I hope that anti-tumor strategy should include reprogramming the host component for synergistic and anti-tumor response. And all these immunotherapies, basically what they are doing is that they are trying to reprogram the host. It's very difficult to control the tumor cells because they can always evolve. But the host, it's your own cells, it's your own, normal cells. So it's very easy to program them, and this reprogramming process is what going to be the future treatment. But most important, I think, as a future scientist, this is what I keep telling, it may not happen in my lifetime, but it will happen someday, that someday people don't care about cancer, okay? They will have cancer, okay, they will take the tablet, and they will be fine, they will die, everybody will die, right? One day everybody has to die, but they don't have to die because of cancer. How many people have diabetes after age 50? I will say half of the population in India above age 50 have diabetes. High blood pressure, after age 35, you have majority of the people have high blood pressure, but they don't die because of that. Many of them have other chronic diseases, but they don't die. As soon as cancer comes in picture, everybody thinks it's a deadly. And this is actually a good news for everybody, okay? This is good news for patient because they don't have to worry about cancer. And it's a good news for doctors, okay? Why? Why it's a good news for doctors? Right now, if anybody gets cancer, okay, survival is months to year, okay? That patient disappears. Doctors lose the patient, right? If somebody have high blood pressure, it's a lifelong, patient. As long as you have clinic, the patient will come, okay? Cancer, okay? So if it is a chronic manner, it's a good news for doctors. They will always have patient. It's good news for pharmaceutical company, okay? Right now, they lose patient, they have to charge a whole lot for a shorter duration of time. So they don't make enough money. Think about allergy, okay? We have lifelong allergy, right? We are always taking these pill or spraying these. It doesn't take much money to make these drugs. These companies are making billions out of these allergy medication, the medication for blood pressure, medication for diabetes. Cancer, they have a very little window of opportunity, So they lose that, they lose. So it increases. And patient, of course, they will be happy. If they don't have to worry about cancer, it's not going to kill them. They have a medicine which is non-toxic, they will take it. And I think it is possible. Someday it will be a possibility. In my lifetime, I hope it will happen. But if not, You guys are all the future. You guys can decide and design, and come up with the idea. It should not be this deadly, okay? If you think the cancer is a bigger problem, heart disease is a bigger problem than that. But we don't cure heart disease, Controlling blood pressure, controlling diabetes is not a cure. Why can't we do the same thing for cancer? We don't have to cure. We don't have to cure cancer. But I think right now the approach is how to cure it. Everything is emphasized like, you have to cure, you have to kill this. It's a beast, you have to kill it. The day we will figure it out that we don't have to kill it, we can keep it dormant, we can keep it controlled, I think we will have a better, therapeutics. So I think that is the conclusion, okay? And now I'm open. Now I think I did the basic coverage of the cancer and metastasis and basic understanding. I hope it is useful, okay? And I think we are almost on the time. Any question you have? Yes. So if you look at Japanese population, the best example, the average average age of life expectancy is 92 years, in Japan. And in those people, if you look at their lifestyle and the way they live and what they eat, their food is very colorful. That's the first thing, okay? These small portion, big colorful food, smaller portion is very important. And they use a lot of soya sauce, which has been already shown to be having a lot of inhibitors, which you can block many things. And also they do some meditation or exercise. Okay, if they are not running marathon, they are doing something like Tai Chi or all those. So your physical activity, your lifestyle, okay, and environment makes a difference. Which genetic advantage? There is no genetic advantage. Okay, so when they have, this is unrelated to cancer or immunology. So when they have created a map of, they call it centenarians. The population where you have maximum people living over age 100. Okay, and there are 20 sites. None of them are in India. Okay, by the way, Japan has 2 or 3 of them. 3 of them actually. There is one in USA which is widely studied in Loma Linda. So in all these 20 centenarian colonies, you can find that they are very well close knit family. So you can find that they have they are not nuclear. They have grandparents, parents, kids, everybody living together. They are very socially connected. Okay, this is all scientifically proven. That they are very socially connected. They are not possessive, they are not owning a whole lot. It's not like they are very rich, but they are very religious and faithful. Okay, so you can see the factors which are coming up. Most of them are related to your lifestyle. I think your lifestyle is very important in the way you live and how long you can live. And actually, you can go and see the map. You can, if you go Google centenarian colonies, you can see where they are. You will see 85-year women, carrying, food, going to like 5-10 miles to give it to son, who is working in a field. Those are the, facts. Earlier, they used to accept. If you look at the today's population, especially teenage, they hardly do any physical activity here. All they are doing is exercising their thumbs. Yeah, there is hardly any play outside, their house. So I think we have restricted a lot, evolving through, our own ways, But all in all, I think your food, the way you live, where you live, and how you interact in the society makes a difference. You have to be stress-free, and you have to have faith. Yeah. Yes. No. So lymph node is the first site most solid tumors metastasize. Yeah. So even in that case, the draining lymph node, you can see, if they are positive, it's a bad news. Yeah. Yeah, but both of them are different. Yeah, genetically different. Yeah, yeah. Yeah, they're not same tumor. Yeah. Okay, then see you guys tomorrow.